This podcast will educate and inform listeners on the various systems and methods that use information, data, and communication technologies to help resolve problems, reduce inefficiencies and costs, improve access, increase quality, and help make the practice of medicine more personalized and precise.
Welcome to SMA's Digital Health and Innovation Podcast. I'm your host, Dr. Andy Mohan, SMA's Digital Health and Innovation Chair. Today we are discussing the history and importance COVID-19, Mr. George Floyd's, and CMS guidelines on autopsies. Our main guest today is the well-renowned physician, Dr. Bennet Omalu. Dr. Bennet Omalu is a Nigerian-born physician, forensic pathologist, and neuropathologist who was the first to discover and publish findings on chronic traumatic encephalopathy, CTE, in American football players while working at the Allegheny County Coroner's Office in Pittsburgh, Pennsylvania. His discovery of CTE made such an impact in the science and sports community. He was played by Will Smith in the Hollywood blockbuster movie Concussion, which was released in 2015 by Sony Motion Pictures. He has also published several New York Times best-selling books, which have been on his life and work, including The League of Denial and Concussion. He has also published his memoir, Truth Doesn't Have a Side, in August 2017. His latest book was published in 2018 and is titled Brain Trauma in Contact Sports: What Parents Should Know Before Letting Their Children Play, as well as many other scientific articles and chapters in books on traumatic brain injury. Dr. Omalu holds 8 degrees and certifications in the medical sciences and business management. He attended medical school and holds a Doctor of Medicine MBBS degree from the University of Nigeria, Enugu, from where he graduated in 1990. He holds a Master's in Business Administration degree from the Tepper School of Business, Carnegie Mellon University, Pittsburgh, Pennsylvania. He also holds a Master's in Public Health degree in Epidemiology from the Graduate School of Public Health in Pittsburgh. Dr. Omalu holds 4 board certifications from the American Board of Pathology in 4 subspecialties of medicine, including forensic pathology, neuropathology, clinical pathology, and anatomic pathology. Additionally, he holds a board certification in medical management from the American Association of Physician Leadership and is a certified physician executive. Dr. Omalu has conducted over 12,000 autopsies throughout his overall career. Dr. Omalu is the president and medical director of Bennet Omalu Pathology and is a clinical professor of medical pathology and laboratory medicine at the University of California, the Davis Medical School. He is an appointed member of the Traumatic Brain Injury Board of the state of California. Our other distinguished guest is our one and only Dr. Deepak Mohan, who has been on our show many times as an expert scientific guest and chief moderator. He is the medical director of pathology at San Joaquin General Hospital in French Camp, California. Finally, our chief moderator today is Mr. Fred Newmark. Mr. Newmark consults as the co-founder and managing partner of Newmark Healthcare Services, working with physicians, hospitals, and group practices. He also has a video series called Behind the Curtain of Healthcare that can be found on YouTube. Doctors Omalu and Mohan, it is an honor and pleasure to have you on the show today. We have a lot to discuss, so let's get started. Mr. Newmark, take it away, please.
So thank you for joining today's podcast. I'm excited to have Dr. Bennet Omalu, as he's already been introduced by Andy, to join us. Dr. Deepak Mohan, and of course, Anand Mohan is on our podcast with us. And today we want to address the history of autopsies. Dr. Omalu has performed over 10,000 himself personally, and we're as well going to include, because of the interesting times we're in, Dr. Omalu, in addition to kind of the history of autopsy, the evolution of autopsy, the importance and the point, I know for a fact that due to COVID, we've seen some interesting results and findings, I should say, based on the value of autopsy. And I don't think as well we should be excluding the autopsy of the unfortunate death of Mr. George Floyd at some point. So Dr. Omalu, thank you for joining us, and I will let you take it from there.
Well, thank you so much for having me. Well, I'm a forensic pathologist and also a neuropathologist. The autopsy, it's about the gold standard of medical evidence. It is what establishes the evidentiary reference standard. The autopsy is relied upon to establish medical evidence. And it's essentially a systematic examination of the human body. It is a multidisciplinary endeavor and multifaceted. But what many of us are typically familiar with is the prosection, meaning the dissection itself. That is just one part of the autopsy. The autopsy is as old as modern medicine. It dates back to the prehistoric times. People have always dissected human bodies for one reason or the other. But in reference to the modern times, historically, dissection of the body for medical purposes began in the Middle Ages, essentially in Eastern Europe, with doctors like Dr. Paganum, Dr. Virchow, Dr. Rokitansky. So 14th century, 15th, 16th, 17th century, then it exploded in the 18th century with Dr. Virchow and Dr. Rokitansky. And then people like Michelangelo and even Leonardo da Vinci added their part, and since the 18th, 19th century, it's evolved. And most recently now, it's become a highly advanced medical tool that could become very technologically advanced. For example, there is something we call immunohistochemistry, whereby we use antibodies to study human cells at the subcellular, meaning even the submicroscopic, beneath the microscopic level. So the autopsy is the gold standard of medicine. The autopsy is a tool, an agent of truth. The primary objective of the autopsy is to establish the truth within the generally accepted principles and guidelines of science and within the premise of common knowledge. So it still remains a very powerful tool. It still remains a very powerful tool of discovery that advances science, that educates us. For example, my work on CTE and many others. There was an autopsy I did in 2002. The first time an autopsy was performed on somebody who died from West Nile virus. This was in Pennsylvania. And through that autopsy, we were able to define how the West Nile virus infects the brain, what happens when the virus enters the brain. So it's a very, very, very powerful tool that is an agent and tool of the truth.
So if I was to transition what you just shared to what we're experiencing now with COVID, a disease and the side effects of a disease that we seemingly are finding out more and more about every day, relative from where we started in early 2020 to what we're seeing now. How has the autopsy helped that evolution of information that's so critical to us understanding this disease from a public health perspective?
Yes, it has helped us tremendously. Personally, I've performed about 6 COVID autopsies. 2 came back positive. Autopsy confirmed those 2 cases. And I've read the work other people have published. So through the autopsy, we've identified or confirmed that the SARS-CoV-2, what we call the COVID-19 virus, behaves like other coronaviruses that cause severe respiratory illnesses. People must know COVID-19 virus, what they call SARS-CoV-2, is not the first coronavirus. We've always known about coronaviruses. In fact, autopsies have been performed 5-10 years ago on other types of coronaviruses. And CoV-2 is behaving like other coronaviruses. The primary organ autopsy has shown the coronavirus infects is the lungs. It infects the lungs. And through other types of research, we've been able to identify the specific types of proteins the virus would bind on or receptors. But in the lungs, the virus infects a specific type of lung cell we call the type 2 pneumocyte. It thrives and proliferates in the type 2 pneumocytes. And the type 2 pneumocytes are the cells that line the spaces of the lungs, the so-called alveoli. The type 2 pneumocytes produce the type 1 pneumocytes that helps you to exchange oxygen between air and blood. So when it infects this type 2 pneumocytes, takes over the functioning of the cell, many times kills the cells, you suffer lung damage. And when you suffer lung damage, there's a specific type of lung damage autopsy has shown us you suffer. It's called diffuse alveolar damage. And then your lungs at autopsy begin to look like the liver. We call it hepatization. Becomes solid. So when you reach that stage, there is no amount of air you pump into your lungs that would be sufficient for oxygen exchange between air in your lungs and the blood. And that is why many of them suffer respiratory failure, low oxygen levels, and need to get on the ventilator. So autopsy has demonstrated the primary mechanisms of infection and the outcomes of infections. Now, once you're infected, your lung is being damaged. Your body responds to the virus through what we call systemic inflammatory response syndrome. Pardon the jargon. Systemic inflammatory response syndrome simply means your entire body is now responding to the virus and the damages being caused by the virus, including your bone marrow. So like the autopsies I have done, the bone marrow will send out large numbers of immature cells. And then your clotting system fails. You develop abnormal clotting mechanisms. And as the virus thrives, your immune system responds to the virus. And some of us may develop diseases like resemble autoimmune diseases. So what autopsy has shown is that there are primary manifestations of the virus. There are two manifestations of the virus, the primary manifestation and the secondary manifestations. So the primary manifestation is the direct damage to the lungs, and then the secondary manifestations, the clotting disorders, the autoimmune diseases, the neurological symptoms, and even long-term effects, the so-called post-viral syndromes. And this does not only apply to the coronavirus, it applies to all other types of viruses.
Have you seen at all, this is, I had heard reported on one of the news outlets that through some autopsies that the clotting problems throughout the body were more pronounced than originally thought with COVID. Have you witnessed that yourself?
Yes and no. The way sometimes it's being portrayed on TV is not factually accurate. I've heard some doctors many times who are not pathologists. So what we are seeing with coronavirus is not unique or exclusive to coronavirus. We need to emphasize that. When you suffer any type of overwhelming infection, especially by an organism your body is naive to, meaning you have little or no immunity against, it causes an overwhelming inflammatory response, but because your body is totally confused. And then when that happens, you develop what we call a disseminated intravascular coagulopathy, meaning you start having clotting all over your body. Mm-hmm. This is a secondary phenomenon that is very well established in what we call fulminant infections, and Dr. Mohan could help me out. So in all types of fulminant infections, you see secondary consequences of clotting disorders that is not exclusive to or mutually unique are exclusive to coronavirus. We need to emphasize that. Even the autoimmune disorders we've seen is not unique to coronavirus or COVID-19 virus. Am I making sense?
You are to
Yes,
me.
absolutely. Absolutely.
Go ahead, Dr. Mohan.
There's one additional point. I think you're absolutely right, Dr. Omalu, that there is this ubiquitous model for inflammatory response, but there seems to be something else as well going on, and it may be related. And again, the science still looking at this. The ACE receptors, which is how the virus gets into the body, are located throughout the entire body. In fact, they're obviously located in the lung on the type 2 pneumocytes, as Dr. Omalu spoke. That's typically the way of entry for the virus, because we breathe in the virus and it goes and enters the body through the type 2 pneumocytes. But once it penetrates that, the vasculature is very close. It's within microns of the type 2 pneumocytes. And the blood vessels also contain the ACE receptors. So the virus can also enter the blood vessels. And once it's in the blood vessels, it can cause a great deal of endothelial damage. So that may be another mechanism where we have this coagulopathy that's taking place. It's more of a microangiopathic coagulopathy, which may be independent of the inflammatory response. It may be a direct result of the virus damaging the endothelial cells. And once the endothelial cells are damaged, as a protective mechanism, we have von Willebrand's factor that gets released, and that itself can set off the clotting cascade. And this is particularly damaging in the brain. And of course, I'd like to maybe ask a question, because Dr. Omalu is an expert in neuropathology. What type of findings we see in the brain, specifically in young people? We're seeing strokes and other neurological findings, and sometimes even dementias that may be caused by the COVID-19 virus. What are we seeing in the brain?
Yes. So for viruses generally, we observe the tropism, topographic tropism, meaning viruses, though they infect your entire body, target specific tissues and organs. For example, the hepatitis C virus, although it's in your entire body, it targets the liver. And like the herpes simplex type 1 virus, although it infects your entire body, but it targets the brain. The coronavirus is a virus that may exhibit similar behavior. In the two cases I've examined, I did not see, and I examined the brain, I fixed the brain in formalin. Any specific change that you will see is unique to the virus, like you will see in CMV encephalitis or HIV encephalitis. You see essentially secondary non-specific changes. So is the coronavirus neurotropic, meaning is it a virus that primarily targets the central nervous system? No, not exactly. The neurological symptoms, many of the papers report on the clinical neurological symptoms, not on the pathological symptoms. Neurological symptoms are very frequent accompaniments of viral syndromes that are due to the cytokine inflammatory reactions. So the presence of neurological symptomatology does not mean coronavirus is neurotropic. For example, the microinfarcts, like we have said, we have an accompanying coagulopathy. Once you have a systemic coagulopathy, you may have some vascular injury to the brain as well, because the brain is part of the vascular system. So my warning or recommendation is, we've not studied this quite extensively, so we need to be very careful as the colleges of physicians across the world in the interpretations and conclusions. What we know is SARS-CoV-2 virus is a coronavirus that primarily infects the lungs. Could there be secondary manifestations of the primary infection? Yes, of course.
So I'm going to ask a question, and either Dr. Omalu or Dr. Mohan, whichever wishes to engage. So as you said, Dr. Omalu, the basic fundamental purpose of the autopsy is a tool for truth seeking. And I think going into it, it's probably best to be completely scientific and neutral and try to go where the facts take one. And I also heard, Dr. Mohan, that you suggest, and you actually gave credit to one of your mentors, Dr. Herbick, for saying healing begins when a diagnosis is rendered. And I'm assuming that comment was specific to the loved ones and family that have lost a loved one. So we're really combining the truth with then leading to healing and the value and purpose of an autopsy. And I'm just curious for how the two of you are seeing that implemented today and how you see autopsy as a service evolving from now into the future because of the very important component that it plays in truth seeking and healing.
Maybe Dr. Mohan, my good friend, will go first.
Yes, I'll definitely take a stab at it, and then of course the definitive description will be given by my very good friend, Dr. Omalu. So yes, the autopsy, as you can see, is a historical tool, and it's something that has been very important throughout history, and has been the way that we have discovered disease. But it has to evolve with the times. Now we have many different new modalities in the laboratory, as far as laboratory testing, as well as radiological techniques, and we need to use those tools as well, pre-mortem as well as post-mortem. And there definitely is always going to be a role for the autopsy, but I believe it's going to be a role that encompasses all the different modalities of testing. Today, as Dr. Omalu, we do autopsies on COVID-19 patients, but on every single one of those, we still do the viral testing that we do on pre-mortem people. It's not, we cannot make a diagnosis of COVID-19 without the molecular testing that we do pre-mortem. So when we say autopsy, it doesn't necessarily, what people think about when you say autopsy is a pathologist with a scalpel in his hand making cuts into a body. That is maybe one component of the autopsy, but the autopsy itself involves all the different scientific modalities, including, as Dr. Omalu says, immunohistochemistry and histopathology, electron microscopy, molecular techniques, next generation sequencing. All the techniques that are available to us pre-mortem are also available to us post-mortem, and it's just an extension of those techniques. And that's my viewpoint. And I think the idea that the autopsy is just a person cutting into a human body, I think you diminish the autopsy when you say that. I think really you're just using all the scientific tools that we have at our disposal to render a diagnosis postmortem. And sometimes the diagnosis postmortem could agree with the premortem diagnosis. It's not to say that there's always a conflict, but sometimes there is a discrepancy. There is a nuance or a new finding that can be potentially found in an autopsy that perhaps was missed during the premortem process. So that's where autopsies can be an educational tool, and that's why the ACGME and up till recently the CMS has mandated autopsies to be part of any program that is being funded by CMS. Recently, the requirement was removed, but that doesn't diminish the role, because pre-mortem we always, for surgeons, they do a surgery, and a few days later a patient dies. It could be for unrelated reasons, but potentially an autopsy can help them see if their surgery went well and if there was any potential areas of improvement on their particular surgery. So all those type of educational activities do not take place unless an autopsy takes place. That's my viewpoint.
Yeah, this is Bennet. Thank you, Dr. Mohan. That was beautifully put. You know, like Dr. Mohan said, a very famous doctor, Dr. DiMaio, about 10, 15 years ago at a conference, said that the autopsy, the complete autopsy, is the autopsy that provides answers to any question that may emerge down the road. So in the 21st century, the autopsy applies every facet, like Dr. Mohan has said, every facet of science. For example, today, for some autopsies, before I begin the prosection, I do a whole body CT scan from head to toe. For some autopsies, after my prosection, I do a whole genome analysis. For every baby autopsy or autopsy I perform on a child, I do mutational analysis of at least 1,700 genes. These are the commonest genes for pediatric diseases. So the autopsy has become a highly sophisticated and scientifically advanced tool. And it is still the standard of reference for medical evidence. It is still the gold standard. And like Dr. Mohan said, whenever there is a discrepancy between clinical findings pre-mortem before the patient died and post-mortem after the patient died, the autopsy findings will supersede. Why? Because the autopsy, you have the privilege to cut up the body, to touch the tissue, to examine the tissue directly, and do analysis you could not have done while the patient was alive. But having said that, medicine as a science is not a pure science. It's not an absolute science. That may be a better terminology. It is not an absolute science like mathematics or physics. It's an applied science, a combination of science and humanities. What does that mean? Even after you've generated the medical evidence, a human being has to interpret it or has to combine the constellation of multifaceted evidence and provide a conclusion or a diagnosis. That is where we fall short. And in that process, all types of conformational thinking may emerge, all types of implicit bias may emerge, all types of confirmation bias would emerge, and many times even simple lack of knowledge and experience will emerge. And that is why it's always important, the traditional practice of second opinions. Whenever you do an autopsy, you must preserve the evidence upon which you based your conclusions on. You must preserve them. Sometimes, from the guidelines of the College of American Pathologists, we store some of these tissues for over 10, 20 years. In fact, in forensic pathology, we store some of these tissues indefinitely. And a good example is the George Floyd autopsy recently. In spite of the prevailing forensic scenario in that case, whereby a human being was recorded, whereby his neck was compressed, diametrically compressed for more than 9 minutes, a pathologist, a competent pathologist, ruled the cause of death as cardiopulmonary arrest. So yes, there are those biases, but having still recognizing the shortcomings of the autopsy as a scientific method, it is still the most viable, the most reproducible, and the most validated tool of truth in modern medicine.
So I think, Dr. Omalu, what I heard you suggest is that the science is science, which to me as a non-clinician although could be interpreted with some nuance, is science. And I usually think of science as being factual, follow the facts. I think what I'm hearing from you, and please correct me if I'm misinterpreting, that some of the variation is actually the interpretation of the science. Is
Yeah,
that what you're suggesting as well?
yeah. Well, no, not exactly. So there are different types of science. The absolute sciences like mathematics, physics, means there can only be one outcome. Like 1 + 1 is 2, and nothing else. But many other types of applied sciences where there is a combination of science and humanities, like biology, medicine, there is some science-human interface that may reproduce some level of or some degree of bias and inaccuracy. Am I making sense? And in the court of law, that is why the standard of truth in the court of law is reasonable degree of scientific certainty, not an absolute degree of scientific certainty, because medicine as a science is not an absolute science.
So is it possible, again, being a non-clinician, that two pathologists could see the same set of data presented from an autopsy and come up with different conclusions?
Yes, definitely. So that is why what the first thing you do among those two pathologists, you look at their qualifications, levels of experience, and their track record. And then you choose which one is more reliable.
Got it. I'm going with the one that's more reliable myself.
Definitely.
So I'm curious. One thing, because when we started our conversation, you took us back hundreds of years to the real infancy of pathology as a science. Does it seem to evolve in your opinion at a high cadence, a fast cadence? Is it a slow evolving science, if you will? I'm curious, being this has really been your career, your whole career, and your passion. Are new discoveries made frequently, or is it rare? Is it completely more dependent on the newer technologies to better, get to the truth of what you're seeing? So overall, arching, is it seemingly evolving at a fast pace, or would you say it is a slow evolving science?
I wouldn't use fast pace or slow, because that is a matter of personal opinion. However, I could say there is a sustained and persistent evolution, like in every sphere of science. For example, less than 100 years ago, we couldn't launch a rocket into space. Today, we are perfecting that science. It's evolving. That's every aspect of every human endeavor, every aspect of our humanity evolves. And as we evolve, we become more intelligent. So the autopsy, being a product or an aspect of our humanity as Homo sapiens, evolves and becomes more intelligent. The autopsy I perform today in 2020, of course, is much, much more advanced and more intelligent than the autopsy Dr. Vercal performed in the 1800s. Mm-hmm. But the fact that it's evolving does not mean that the autopsies done much earlier were inaccurate. No. It depends on the reference to the standard of truth. But as autopsies evolve, autopsies become better, become more intelligent, because science as an endeavor is evolving and becoming more intelligent. So the autopsy, the evidence generated by the autopsy is indisputable, because that's a scientific fact. For example, if I look at the tissue slide of somebody with COVID-19 and I see diffuse alveolar wall damage, that is what it is. It's indisputable. So the scientific evidence is scientific, it's factual. But the interpretation of that evidence, some other doctor could come and say, Dr. Omalu, I disagree with you. This is not diffuse alveolar wall damage. This is eosinophilic pneumonitis. It's all a matter of personal opinion or professional. The science is the same. Did that make sense?
Yes. So how frequently is it that maybe more than one set of eyes needs to interpret the data from an autopsy? Is that more the rarity, or is it more in more the like high profile cases of, you know, celebrities and people that most of the world is familiar with? Or is that more frequently perhaps than I realize that occurs day over day? Just curious.
Well, Dr. Mohan, what do you think?
No, I think that this is second opinions is part of medicine. You know, it's not just part of pathology, but you know, in every arena in medicine, you know, it depends on the stakes. You know, if you're going to be irradiated and given toxic chemotherapy, and it's based on a particular diagnosis, then I would want a second opinion before that particular treatment takes place. So obviously, there's also the acuity of the situation. So if you're suffering from cardiopulmonary arrest and somebody wants to start CPR, that's not the time to ask for a second opinion. They have made a diagnosis of that you need CPR, and they go ahead and start CPR. Whereas if there is a condition where particular, you know, you can take some time, and most times in surgical pathology, there is enough time to go back and review things and make a decision. In those cases, a second opinion is warranted, and many times it can provide very useful information and generates the best outcomes for the patient. Now, in autopsy, time is not a factor. I mean, there is some general regulations that we'd like to complete an autopsy within 30 days and so on and so forth. But those are only rules of thumb. If I want to take maybe 90 days to complete an autopsy, that luxury is afforded because it's post-mortem. So you do have enough time to go ahead and secure second, third, fourth opinions if necessary, if there's controversy. And there are some controversial areas in medicine, and not just in pathology, in all of medicine. There are controversial areas where you may need to seek multiple experts to find the truth, because some of this can be subjective. So, and you know, I'll definitely defer to Dr. Omalu on this, on what percentage of cases, but I would say as many as needed, because there's no time constraint on an autopsy.
Mm-hmm.
Yeah, but what Dr. Mohan said is very true. Because we have the colleges of physicians, we need to practice medicine in a collegial manner for the good of the patient, for the good of society. It's not about the individual physician. So in pathology, for example, I may be wrong, correct me, Dr. Mohan, if I'm wrong, that the quality assurance, quality control, about 10% of your work needs to be reviewed by another physician independently, just to make sure you're not allowing your biases and personal beliefs to get in the way without you even knowing it or being aware of it. So like Dr. Mohan said, there is no emergency in autopsy practice. The patient is dead. Okay? So I will use myself as an example. In my practice, I have about a panel of 3 other forensic pathologists I frequently consult on cases. And these other doctors, all I need to do anytime, any place, I pick up my phone, I call them. Sometimes I may even take a picture of what I'm seeing I'm not sure of and send it to them. The best physician is the physician who knows his or her limits, who knows when to humble him or herself and seek guidance. It does not mean you're less intelligent. It just means you're smarter, because you recognize that you cannot know it all. And so it is proficient and a sign of high competence for every physician to seek assistance, second opinions, and guidelines frequently, not only on high-profile cases, but routinely. Make it part of your practice. It wouldn't lead you to trouble, and people will even respect you. And going back to the George Floyd autopsy, when the autopsy report was released, this is one of the highest profile autopsies you can ever imagine. This made international news. The first time I checked in the autopsy was to see how many doctors signed the report, or to see a statement. This report was reviewed by so doctors and they concur with the diagnosis. I've done that with Dr. Mohan frequently. He will confirm that. I saw none. The report was signed exclusively by one doctor, Dr. Baker. And I shuddered. That surprised me. And then when I began reading down, the first thing I said, if this doctor had stopped and sought a second opinion, independently, not a second opinion from doctors who work for him because he's the chief, but call another office, hey, read this report for me, which I have done. That was a very high-profile case I did. Sandra Cantu, a young girl that was killed by her female neighbor. I showed it to 3 different pathologists before I finally released the report. And there were changes they recommended I make. So seeking a second opinion, it is very good practice. It's not about you, but for the good of humanity, good of society, and good of the patient.
Dr. Mohan, is there, by way of practice, a certain percentage, as Dr. Omalu was suggesting, that is protocol for autopsy finding review, whether it's a quality review of a pathologist? Are there any protocols in place that, or is that completely voluntary for a pathologist who perhaps just want to get better on their own, make sure their skills are good, or is there an auditing sort of process in place?
Yeah, so that's a great question. So, there's some general rules of thumb. Now, it's up to the individual medical director of the facility to make the rules more stringent, but typically 10% is probably the baseline. And so there are prospective and retrospective reviews. So prospective is it's an active case, and it's this what Dr. Omalu is talking about is you have a physician review the case before it's being signed out, before the case is being finalized. So that is a big component of what we do, and typically that's where we focus. And so, as a percentage, that might be, depending on the cases. If it's a routine type of case where it's not very complex, your percentage of review will be fairly low. And we also have set criteria. If it's a new malignant diagnosis, if there is any kind of discrepancy between the radiological findings or the clinical findings, if there's any discrepancies in the previous findings. So there are certain set criteria that we have focused on to automatically generate a prospective review. That means before the case is signed out. So that can be up to 20-30%, depending on the type of caseload that you have. If you have many cancer diagnoses in your caseload, and then in that case you'll have more of those being generated. Now, if you have mostly benign diagnosis, that could be lower. So it all depends on the type of cases you're dealing with. Now, the retrospective cases, that is depending on each facility. 10% is a good rule of thumb. So that's typically where we start with like, let's say, having a random review. So this means that it didn't meet any of the criteria, but these cases are being reviewed at random by a second pathologist to make sure that quality is up to snuff. And so that process, we do that with our cytologies as well as our pathology specimens, where it's completely random, and some of them can generate a new finding, and those are reconciled. If there's any continued disagreement, we typically will send it to an academic center. Most private practice pathologists, maybe there are 2 or 3 pathologists, and they may have some expertise, but they may not have the highest level expertise. So on some cases where there's a disagreement between 2 pathologists who have about the same level of expertise, they may send it to a 3rd pathologist. And typically we like to go to a university setting. And in the university setting, there might be people who have spent their entire careers looking at a particular illness or disease. So they truly are experts because they may have, some disease, and then we don't see maybe once in 15 years, maybe once in 20 years we may see a particular illness or disease. And obviously, just based on what we've read in the books and what we've seen, we should not render a diagnosis. We should have experience with those cases. So that's when these type of cases go to a academic center, whereas we may have seen only once in 15 years. Over there, they may see 2-3 cases a year because they're reference center and they get many cases from all over the country. And so these people publish and are true authorities on the particular condition, similar to CTE, who my esteemed colleague Dr. Omalu, who found that condition in football players and named that for football players. They may be an authority who have discovered a particular disease, and they may have written about the disease extensively. So these are the people who are in the best position to render a diagnosis that may not be very common. So that we use a different approach to different type of cases. And I guess the long answer to your short question is, it all depends, but these are kind of rule of thumb that we use, and it all really depends on your practice setting and the type of cases that you receive.
That's a very refreshing answer, Dr. Mohan, and from my perspective, let me explain why. And I understand that there's already a death when typically a pathologist has come in, obviously, to do an autopsy, so there's already an outcome, and we're just trying to determine the truth of the outcome. But in my experience in working in community hospitals or with community hospitals for a good period of my career, I think sometimes these sort of audits are triggers because of red flags that appear, if you will. And I don't know that there's enough proactive quality approach, or there perhaps could be more on the community hospital setting side. And of course, I'm just speaking for myself and my experience, that I clearly, when there are red flags, when a cardiologist is seemingly doing way too many stents or way outside of certain parameters, there's some indicator that would then call a peer review or an outside organization to review, but there's a trigger that perhaps caused that review. And I'm hearing from you in the pathology world, there is some quality that's baked in to wanting to make sure that the science is accurate, that the pathologist is doing a good job, and it's not triggered because of a red flag, if you will. It's triggered for quality measures. Am I sort of understanding this correctly?
You're absolutely correct. And the reason why pathology is more quality oriented is the clinical laboratory is heavily regulated by the federal government. In the 1960s, there was a clinical laboratory act that took place that regulated all the laboratories throughout the country, because you could go to a laboratory in California and have a complete metabolic panel done, and you can get completely different results if you go to the East Coast, in New York, and to another hospital. So that was a major issue in the 1960s, where you couldn't get these kind of discrepant results. And so they really wanted to tie all these results together and create a sort of a national registry for this. And so some of the organizations like the College of American Pathologists and some of the other organizations out there, American Society of Clinical Pathology, got together and they came up with a proficiency testing program. So what we do is 3 times a year, we send samples to throughout the country. This is a national archive of samples that are sent, and they're unknowns to the laboratory. So we're not allowed to share these samples. This is the one time we cannot share our results and compare results and ask other people's opinion. We have to result the information, and at the end of it, they compare our results to every other lab in the entire country. And that's the way we kind of know where we fall. So if we're out two standard deviations outside of the norm, then there's something wrong with our test. And if there might be a bias or there might be some issue with our test. So then we know that we need to kind of carefully look at that particular analyte. Every single test that we do in the laboratory, it goes through this process. So this is our proficiency testing program. it's had a phenomenal run of success, mainly because we've been able to standardize our lab tests not just in the local regional area, but throughout the nation. Because before, if you're a university laboratory, then maybe you're the standard. Now there is a national standard. In fact, you can pull up this information if you go to a laboratory anywhere in the country and request their proficiency testing results. You can get those results from those laboratories. If you're a physician, you can ask, hey, I don't believe your sodium are accurate. I see a lot of problems with it. I'd like to see your proficiency testing results for the last couple of cycles. You can take a look and see how this lab compares with every single lab in the entire country. Now, on a daily basis, we also do quality control as well. This is the prospective versus retrospective. Obviously, if you're only doing 3 times a year, there could be 2-3 months that go by when you have all these erroneous results, right? But on a daily basis, our quality control is our bread and butter. So we have known samples. Usually, we run a low, a normal, and a high quality control on each sample. So let's say a known sample of since we're talking about sodium, 140 for sodium versus 125 versus 100. So we know those are the sample, and then we see how the instruments respond back to those knowns. So if everything comes in within the normal statistical realm, then it's fine. If something is off, then we do not perform testing on that device that day. So we figure out what went wrong, we do a calibration, and there could be a myriad of different things that potentially could have caused a result to go awry. But within, there are some tests that are mission critical that will go ahead and do every shift. That means every 8 hours a QC. Some are done once a day. So depending on a risk assessment, we determine how often we should do the QC. And then the third method that we use is a moving average. So every laboratory has an established sort of population, and we kind of know sort of a moving average of a particular analyte. So if it starts to deviate in any way, we know that that particular analyte, there's a problem with it. So even before the 8 hours before we do the QC, we'll know based on the moving average that, hey, all the sodiums are showing high. That's not normal. Typically, maybe one patient might be high, but not everyone should be high, right? So that moving average is another tip-off. And we typically will look at maybe 10 to 15 different very frequently used analytes as a moving average. We can't use every single analyte, but typically those 10, 15 ones are very mission critical. We'll look at as moving average. And if there's any problem immediately, that may also tip us off to other problems with other analytes too, because typically these analyzers do a lot of other tests. So if there's any issue with any one analyte, we'll put the entire system down for maintenance and make sure that all the calibrations are run and repeat all the QCs to make sure that there aren't any issues. So these are all the mechanisms that we do in the laboratory. And this has evolved over time, but these are all good laboratory practices, and 95, 99% of the labs in the country would be following these. And the 1% that do not, they can be discovered very quickly, because every 2 years, the College of American Pathologists comes in and does an audit to make sure that all these things are being done.
Deepak Mohan for president. Are you ready for the run? I'm going to be your campaign manager.
Maybe for the college. Maybe for the College of American Pathologists.
You let me know. Well said. So I've got a couple of thoughts, and then I want to bring up one last subject to kind of close us out. So I'm going to digress slightly, but I'll try and do this quickly. One is, again, I wish there was more proactive quality of care measures from a review perspective, like you've shared with us across the spectrum of healthcare. I can tell you that things like making sure charts are done correctly is a norm. There are chart audits that are done, but that is so much tied to remuneration. And this is a rhetorical comment. I'm not asking anyone in this call to reply or give their perspective. I'm just saying I wish that across the spectrum of healthcare, there was more of a proactive quality approach that was really designed strictly to delivering the highest level of healthcare that we can as a society. On a second point, I did want to just mention that I've had the pleasure of hearing Dr. Omalu in a prior podcast, and now I'm actually live on the phone with him, which is just incredible for me. And I just want to comment to you, Dr. Omalu, I listen to when you say things like, for the good of society, things that talk, when you make comments like, a pathologist that seeks a second opinion is actually smarter. There is a humility about you, Dr. Omalu, a heartfelt caring, a heartfelt connectivity that I know I sense with you. So you're not only a very bright scientist, pathologist, physician, whenever you speak, and your laughter is contagious, by the way.
Don't make me self-conscious.
No. I honestly, and this is heartfelt from you bring layers to any conversation that are human. Your caring is self-evident, and your humility to me.
Enough. What do you need? What do you need? I'll give it to you.
I know. No. I'm really coming from a heartfelt place, Dr. Omalu.
Thank you. God bless you.
Yes. No. You bring so many sub-layers of context to the conversation, and the fact that I'm actually engaged in this call, in this podcast with you is a real pleasure and a.
May I give you the foundation for that?
Please do. Please do.
You just said I've done over 10,000 autopsies. I've done about 12,000. Okay, and I've done autopsies on the 20-week-old fetus, on the 9-year-old girl, on the 27-year-old bride who died a day after her wedding. I've done autopsies on a multi-millionaire worth over $250 million. I've done autopsies on the homeless man who couldn't afford any meal. I've done autopsies on people who were born on my birthday. I've done it all. And I've seen and recognized that there, but for the grace of God, go I. That I came from nothing, and I shall go back to nothing. So who am I? And through the autopsy, through the practice of science, I discovered faith. And I practice science in my faith in science. And science and faith share one common end, the truth. So through my faith and science, I discovered that we all are members of one another. That whatever we do, even to the least of us, we do to all of us. So whatever I do, even to the most vulnerable of us, a dead body on an autopsy table, I do to me because he is a member of me. And so that is what defines who I am, what I do. Now, and if you say it's humility, whatever, no, all it is I'm very conscious and aware of my mortality. I'm going to die someday, and somebody may perform an autopsy on me. And on that deathbed, what would really matter is how much difference have I made in the life of another. That is what will matter when I'm taking my last breath. Well, thank you so much. That was very generous and kind of you.
Thank you, Dr. Omalu. I'm just going to say thank you. Silence is all that's deserved after what you just shared with us. Truly. So whichever of you want to address this, just to wrap us up, and we're probably a little limited on time. Dr. Mohan, you had mentioned earlier that CMS had made some guideline changes of late. I'm just curious, again, I'm not a clinician, and the audience may want to better understand what those changes actually were.
Well, I'll go ahead and describe the changes, and maybe I can get Dr. Omalu's opinion. So essentially, the CMS, which is the payer for Medicare programs, all along had a rule that to participate in their hospital-based program, you need to be able to provide autopsies. That was part of it. It was a requirement as part of being paid by the CMS, which is our Medicaid, the biggest payer that's out there for most of the hospitals. So this was being followed universally by every hospital in the country. Up to recently, in March, there was a rule change that took away the regulation that you needed to be able to do the autopsy. And the rationale was that they want less regulation and that some states already have some rules. And so the states should take over and provide the guidance on autopsy. Now, it's fairly new. It's a new rule change. It only took place in March, late March, April. So we still don't know if there's been an impact in the change of number of autopsies done and so on and so forth. But I think it does warrant some discussion, and that's the reason I brought it up during the conversation. And it's an excellent question, Fred. But I'd like to hear Dr. Omalu's thoughts on this.
Well, I don't know the CMS changes specifically, but what I know is when I was a resident or fellow, the hospitals could no longer bill. Dr. Mohan, please confirm that, can no longer bill for autopsies as a billable item.
That's correct. They're not billable, but you needed to have the autopsy present to be able to bill for other CMS activities.
Okay. So when that happened, when the hospitals cannot bill for the autopsy specifically and charge a fee, that resulted in a precipitous decline of the incidence or prevalence of autopsies. And there was down this consistent migration of hospital autopsies to the forensic autopsy. And also there was an attendant drop in doctors specializing in autopsy pathology because it was no longer, billable. Okay, so that has impacted science in a negative way, really. And my only recommendation is that should be reversed. The autopsy is as legitimate and as valid as an open heart surgery. In fact, a judge once referred to me as the autopsy surgeon. The autopsy is such a powerful tool of discovery. So we should not minimize it. Rather, we should lift it up. And my strong recommendation is that we should go back to what it used to be. Hospitals should be able to bill directly for autopsies.
Makes sense to me.
Yep. Since it's such a powerful quality control and quality assurance tool.
Yeah, it does not make sense to me that it should be tied to something forensic, to I think your point earlier. So, all right, gentlemen. Well, I cannot thank you both enough for joining me on this podcast. I want to thank Dylan for the man behind the scenes for creating this platform for us with affiliation with the Southern Medical Association. Dr. Omalu, thank you again. It's a pleasure to speak with you directly and in person. And Dr. Mohan, again, thank you for your participation in today's podcast on SMA. Wish everyone a great weekend and look forward to visiting with you all soon.
Thank you so much. God bless you.
Thank you, Fred.
Thank you, Deepak. Really appreciate it.
Thank you, Bennet.
Thank you for joining us. To subscribe to additional podcasts, visit sma.org/podcasts.